All right, I tried another USB port with my lapel mic. My microphone says that I'm on. So now can we hear? Christy says I hear. Thank you, Lord. All right. Well, listen, let me just kind of backtrack here. Just kind of introducing myself and just basically getting started. But let me just kind of get back on track here. Let me get my, I got to get my, let's just kind of, I was having some challenges here. I've just got to get my, I have a USB mouse, and so I cannot move my mouse if I don't have the USB plugged in. And so let me just kind of just briefly let's just kind of pretend that never even happened, just kind of like that flood renovation commercial. And I just want to thank you for joining me tonight, taking time out of your busy schedule to really strengthen your practice as a nurse educator. And I'm Keith of Keith RN. It's my passion and my mission to really strengthen and transform nursing education. And really, I think, as we all know, clinical judgment is the hot topic, and it's really been something that's foundational to a practice-based profession. Clinical judgment is nothing new, but we're struggling to teach it and develop it right now in our nursing students. In fact, as I've shared before, according to one recent study, Kavanaugh and Svita from the in Ohio with the Cleveland Clinic, 23% of graduate nurses who all passed the NCLEX did not meet entry-level expectations of clinical judgment. That's a problem because that impacts patient outcomes. And I think it's really important, as educators, I think, I'm just going to kind of go off the cuff a little bit here, but I think that, when we look at, teaching nursing, we must remember that everything that we do impacts patient outcomes for better or for worse. And I know that oftentimes we focus and almost obsess about NCLEX pass rates. And I understandably so. We don't want our program to be on probation by the Board of Nursing, but let's never lose sight. And this is really my strength as a nurse who's recent in practice for 36 years. I've never left the bedside. We've got to make sure that we're connecting academia to practice. And that's really my passion with Keith RN. And the case studies that I write, the tools I develop are really just my best effort using educational best practices to bring practice and academia together so we can practice clinical reasoning, clinical decision making, because it's the most important cognitive skill our students must possess. So therefore, it needs to be practiced, just like sterile technique. It's really no different. So we're going to be talking about some of the best frameworks to record. And Kelly Johnson, thank you for sharing this. Recording is available on my Facebook page, Keith RN, Think Like a Nurse. And you can like that page and you can get the updates automatically. But the bottom line is there's a video header. And under those videos, I've been doing Facebook Lives for over a year. This has been something I've done for about every other week for the last year plus. I really enjoy this chance to connect and just to really dialogue with educators and share some good pearls and help us strengthen nursing education together. So it's on that page, and there's a link. You can share it with faculty. I've got other topics on clinical judgment and critical thinking and incivility with Cindy Clark. So please check it out. So thank you so much. And so I want to let you know, we're doing a series over the summer on clinical judgment, hot topic, and really talking about what is clinical judgment and best frameworks and approaches to teach it and develop. And last week, 2 weeks ago, on a very first beginning of our journey, we talked about defining clinical judgment. And I want you to know that there's a YouTube I did for about 3 minutes. So if you missed that 40-minute chat 2 weeks ago, you can watch all 40 minutes, or you can watch a 3-minute YouTube. And Amy will put that link in the chat. But the essence that I think it's really important to remember from the definition of clinical judgment, so we can teach it most effectively, is that clinical judgment is an outcome. It's the conclusion or end result of a nurse who critically thinks by applying knowledge to the bedside and then reasoning with that knowledge, clinical reasoning, thinking in action at the bedside, leads to the outcome of a correct judgment. So you can't teach it directly. There's no product, there's no resource from anyone who's going to kind of save the day. We have to teach differently. We have to eliminate infobesity, TMI in our lectures, in our content, bring it down to the bare necessity, go deep with what's most important so that our students can reason, apply, and use it at the bedside. So just a really important principle I want us to know. And I also want you to know that I have a Facebook group that I'm the admin for called Teachers Transforming Nursing Education. It's got over 8,000 educators from around the world, United States and Canada. And there's a link that Amy will put into the chat that if you're not a member, this is a supportive community. You know, I'm glad to answer your questions in our chat today. But the bottom line is that you can go right to this group, get a member. You know, it's a closed group, so you got to basically let me know you're an educator. I'll let you in. But the bottom line is ask any question, respond to questions, and it's a wonderful community of supportive educators. And so I just want you to know that that resource is available to you, and I'd like you to basically check that out and have that opportunity. And you know, I have a chance to read the posts inside that group, and I just kind of came across a post I want to take just a couple minutes to kind of just talk a little bit about, because I think it's really, really important. And I think we need to remember that transformation of nursing education begins when we as educators transform academic culture. And you know, there's an elephant in the departments that many of us work in, and it's called incivility and a devaluing and disrespectful work environment. And you know, an educator had this post that just really broke my heart, kind of touched some raw nerves that I just want to briefly comment on, and just kind of would value your feedback and anything that you would like to add to this. But this educator posted this: has anyone quit a job due to an unhealthy work environment? I complained all the way up to the president to no avail. I've just finally retired due to the constant abusive behavior of certain faculty, which were reported to administration and HR. I would like to know everyone's thoughts. This was a job I really liked and was forced out, and the pressure from administration and others has been going on for years. I've gotten a really good job that I love and supported people around me, but unfortunately it wasn't in education. And you know, it just breaks my heart because, you know, there's a shortage of nurse educators. We need you where you are, but our work environments aren't often supportive. And I think it's really important that we recognize that we need to support each other. We need to respect the differences of other educators. We're not all alike. You know, I'm kind of a unique bird, and I wasn't always respected or valued, but you know what? I'm Keith, and I have something to offer. And I think every one of us here have something to offer. And you know what? I just want you to know that your life is a story. And oftentimes, like a story, there's a villain. And you know, if you look at it, fairy tales like Cinderella, the Lion King, those villains derail the purpose of the heroine or the hero. And you know, you are needed right where you are. And I just want to encourage you to persevere, or to really look at an open door, because Keith RN, ironically, was birthed because the door shut for me in academia. When I was transforming the way I taught, I wasn't valued by my department. And I was a temporary probationary hire for 1 year, and they shut the door. And they didn't want me back, even though I was invited to speak at a national conference for nurse educators because of my innovative work. And it was incredibly painful. But that another door opened, and here I am, and I'm still going strong. And so I want to encourage you all, if you're in that position, persevere, but don't take abusive behavior, but realize another door may be opening, and don't hesitate to walk through it or stay the course right where you are. So just some thoughts to consider. And, you know, as we look at today's topic of clinical judgment, we're going to be talking about tonight curricular frameworks to teach clinical judgment. And so what I want you to be, you know, we talked about part one about defining clinical judgment. Today, we're going to be talking about curricular frameworks. And I want you to know that this series is inspired by a recent publication that I just produced about 3 weeks ago. And it's called A Faculty Guide to Develop Clinical Judgment, Transforming Nursing Ed Through the Use of Clinical Reasoning Case Studies. And this is available. I can be glad to give you a 20% discount using the Transformer code. It's less than the price of a case study, but it's the foundation of everything that I'm going to be sharing tonight. And so I just want you to know that if you like paper or even a PDF doc, you can get it either way. Bottom line is you can have something to put your fingers on if you need it. So as we talk about clinical judgment, I'd like to know, what are your questions about clinical judgment and the best ways to teach it? So I'm going to be keeping my eye on the chat and would basically just kind of like to know where you're at. But yeah, I just want you to know, Tracy and Dr. Michelle, thank you. I like to keep it real. I'm just an everyday educator, have my PhD, but that doesn't make me a scholar. Just makes me, sometimes it's the hardworking and diligent dude. But you know what? I just want to really kind of, hopefully encourage and share my story. And you're right, Tricia. Academia does not value innovation. And I think that's really kind of like, what I struggle with is that why do we resist change? Dr. Benner, 11 years ago, came out with a book called Educating Nurses, a call for radical transformation. That's called radical change, by the way. It's not just flipping classrooms. It's not just, kind of just going to a concept-based curriculum. It's about radically changing the paradigm. And to me, the education practice gap, this disconnect between how nursing is taught and practiced, is really ground zero of transformation, as well as incivility is kind of a close second, in my opinion. And so let's bring practice, real world clinical judgment, and decision making into our content. And so anyways, Jennifer, thanks. I'm glad you liked it. Just reread it. Such a terrific read. It's not huge, about 40 pages, so you can easily go through it. But I used my dissertation and what I learned as a PhD student and now a PhD nurse educator to kind of bring a little scholarly level to it. And I hope you found it helpful. So thank you so much. But what questions do you have about clinical judgment? And so I'll keep my eye on the chat, but I just want you all to know that, D-Day is coming. And what is D-Day? That's called NextGen NCLEX in spring of 2023. And, we don't have to fear that. And, if we're teaching differently, if we're bringing active learning that brings real world practice, and we're using the right curricular frameworks to teach clinical judgment, no fear. No fear. And so that's really my goal with tonight's kind of Facebook Live. Let's talk about the curricular frameworks. And there's some resources that are out there that can serve your needs. One is the faculty guide that I've written. I also have another book. And again, this is not to just hawk my stuff, but I've got a book called Teach Students to Think Like a Nurse that I wrote 4 years ago that really takes some of the essence of clinical judgment in the classroom, the clinical simulation, and other approaches. And so if you go to my website, keithrn.com, that resource goes a lot deeper than the faculty guide. But I want you to know that as we look at the essence of what's coming with NextGen, they're case-based scenarios. They're primarily 6 questions based on the 6 steps of the NCSBN model, and they really, essence, replicate Tanner's clinical judgment model. We're going to be talking about that here, and many of you are not familiar with Tanner's clinical judgment model, so we're going to go there in just a little bit and go there. And so let's talk about processes. How do we teach and develop clinical judgment? Now, let's start with framework number 1 that I think almost all of our programs are using. It's called nursing process. And nursing process is not going to go out of style anytime soon. And it's really a foundational, relatively simple framework that a nurse uses to clinically reason and to really, in essence, critically think and to work through a patient care scenario. And so I want you to think of these frameworks of clinical judgment in your curriculum, and let's ask yourself, are they there? Nursing process, I bet you, is in every one of your programs. It is embedded in your curriculum from day one with fundamentals. Your care plans are grounded in ADPI, and all that goes with it. And so just like the curriculum is simple to complex, so should our curricular frameworks to teach clinical judgment. So let's think of nursing process as our foundational, simple framework. That's the foundation. But we need to remember that nursing process isn't the problem. The fact, as I've read some articles on NextGen NCLEX and the new NCSBN model and how we should adopt it as our curricular framework and saying that nursing process, I read in one article recently where it says that they've suggested that nursing process is the problem and should question if it is the best decision-making model after 60 years. And I strongly disagree. I would say that the problem that we're struggling to teach and develop clinical judgment is not because of nursing process. It's how we're teaching it in our programs. And so let's kind of take a look here. Many of us know, I think we've all memorized the 5 steps of nursing process: assessment, diagnosis, analysis, planning, implementing the plan of care, and evaluation. I'm not going to go over that. But there is something I think that as educators, we really need to be aware of that is going to hinder our abilities of our students to think like a nurse. And that's the second step of diagnosis. We have assessment, but then we tend to focus in some programs too heavily on diagnosis. And what I'm referring to is the heavy or the use of NANDA, nursing diagnostic statements, to establish a nursing priority. A 3-part correctly worded NANDA, nice nursing diagnostic statement, does not capture the essence of how I think in practice when I'm caring for patients, and it doesn't capture the essence of how you think as a nurse in practice. Yet we teach it. Why? It's academic. It's a nice exercise. A written care plan that's kind of a little over, that is kind of insisting on 3-part statements and even a little lengthy. We have no evidence to support that that's an effective way to teach nursing. Yet we do it decade after decade. And so nursing process isn't the problem. It's how we're teaching it and using it. And sometimes we're over-relying on NANDA nursing diagnostic statements. And, you can disagree with me, but if you have some thoughts, I'd love to listen. I'll keep my chat open and see if I'm gonna if I've caused any ire or if anybody says amen. But I want us to focus on analysis, because really after you assess and collect the data, then you analyze it. And that really captures the essence of the second step of nursing process. And Tanner calls that interpreting, recognizing the meaning and the significance of the data. So we'll talk about that in just a moment. But if we want to develop clinical judgment in our students, continue to use nursing process, but please hold NANDA loosely and let your students analyze, not diagnose, and be beholden to a 3-part nursing diagnostic statement, or insist your students use one of the 200 NANDA statements on their card, furiously looking for the right NANDA statement to fit their patient. I had my advanced students doing that. That's crazy. When I look back, I was just a clinical adjunct. I had no power to change it. I look back and saying, what are we doing? And I think as educators, let's question authority. Let's question the way we teach, and let's align it with practice. This is not rocket science. We're teaching a practice-based profession. We must align it with nursing practice as it's taught in the real world. And let's get out of the ivory tower, really. Get away from NANDA and 3-part statements. And so anyways, I'll kind of look and see any of the thoughts here. I teach priority instead of NANDA, Chelsea. I think you're spot on, and I totally agree with that. And what's really the priority issue in your own words? And Jennifer says NANDA has been a bugaboo for too long, especially with Nick and Knock. It's not evidence-based practice. And so I think I'm preaching to the choir. And so it's exciting to see. And so thank you for sharing. Great to see some of these things. And, Tricia says the exact NANDA nursing diagnosis isn't what's important, but identifying the issue What's the problem that gives us direction? So yes. So, if I could encourage any of you as nurse educators, let's hold NANDA loosely. Let's focus on analysis, the nursing priority, in your own words, that captures the essence of the patient problem. Pat Benner in Educating Nurses, one of the book that influenced me so dramatically in my journey, one of her aspects of clinical reasoning that she talks about is that it's capturing the essence of your patient's problem. And so let's teach, if we can teach our students to capture the essence of their patient, that's really the essence of their priority. What's kind of that priority that captures the essence? Let's reason, let's bring practice. And so I'm encouraged, and I hope that we can all do that. But the second framework that I want us to build on with nursing process, and I've shared this before, and so this is going to be a repeat, nothing new information, I haven't changed my mind, is Tanner's clinical judgment model. And Chris Tanner, she was an early colleague of Pat Benner's in the 80s and 90s and 2000s. Chris Tanner was the chief editor of our premier nursing journal, Journal of Nursing Education, for over a decade. She's now retired, but she's a rock star. And Tanner, in 2006, synthesized 200 studies in nursing on clinical judgment. And she came up with this article titled Thinking Like a Nurse, a research-based model of clinical judgment. And Tanner's clinical judgment model, which is really a reasoning model, it identifies 4 sequential steps that really capture the essence of how a nurse thinks. But I wanted to share a couple thoughts from Tanner's framework that are really important. Tanner recognized that clinical judgment is influenced more by what the nurse brings to the patient care scenario. So in essence, it's not so much how the nurse, it's not the data of the information that they collect, but it is how engaged is the nurse? How caring are they? How much of the valuing the dignity of human life and their experience that are influencing how the data is filtered? Tanner made it really clear in this article that it's not just how a nurse thinks that's going to influence the judgments and decisions made. It's also how much a nurse cares, that they must first care like a nurse to think like a nurse. And that's a powerful principle that we must communicate to our students today. So I value, and the insights of Tanner's framework are so important. And you're gonna, Amy put the link to the article. You can download the entire 6-7 page article. I want every one of you to do that. If you're not familiar with Tanner's clinical judgment model, you must be, because it is probably the best framework that aligns with nursing process to teach clinical judgment. And so we're going to go over the 4 steps of Tanner's framework. And the very first step of her reasoning framework that leads to the outcome of a judgment is number 1, noticing. These 4 steps of noticing, interpreting, responding, reflecting need to be on the tips of our students and us as educators just as much as ADPI is. We need to align Tanner's framework of her 4 reasoning steps because they build on each other. Tanner, kind of think of Tanner's as a more complex, kind of like the simplest nursing process. We're going to build on it with other ways of thinking, and that's Tanner's framework provides the foundation. And ironically, the NCSBN model of clinical judgment, in essence, borrowed exclusively and very heavily from Tanner's clinical judgment model. So if we're using these 4 steps of Tanner, they also align with all 6 steps of the NCSBN model. We don't have to use the evaluation model as a curricular model, and we'll talk about the danger of that and why. But number 1 is noticing. So what does the nurse recognize or notice when they're collecting assessment data, and why is it significant? That's step 1 of the first reasoning process of Tanner. So noticing and assessment align. Then it's interpreting. What is the meaning or clinical significance of the data that was noticed. Can you recognize that if that patient, for example, has tachycardia, that is going up and the blood pressure is going down and they are at risk for sepsis, could that be a problem? Are we interpreting the data, the meaning, the significance of the lab values, the assessment data that we're collecting? See, this is where we have failure to rescue, is really a failure to recognize a problem until it's too late. That noticing and then the interpretation. This is ground zero where we can teach our students to save a life. The third step is responding. How will the nurse respond with the correct nursing priority and plan of care based on what was noticed and interpreted? You see, it builds on everything, and responding aligns with, with ADPI and the planning and the implementation of nursing process. It's just basically saying it differently, but in essence, it's the same thing. And reflecting is really evaluative reflecting on your thinking to make that correct judgment. And so that's the essence of Tanner's framework. And, as educators, there's some things that we can also do a little differently to kind of help develop some of these reasoning skills. So, for example, when it comes to noticing and interpreting, let's look at interpreting, for example. We must teach our students some fundamental skills that go with this, that are reasoning skills. For example, trending clinical data. Does your clinical paperwork require your students to record the most recent lab value, the most recent vital signs, and the most recent assessment findings in the paperwork? So when they collect their own vital signs and assessment in new labs, they can see a trend. They can see, is my patient improving or worsening? And so that's, in essence, a really important principle or a skill of clinical reasoning that's going to lead to correct judgments. So we need to identify and teach these specific skills as well. And so I just want to briefly show you just to kind of a visual here, just to kind of show you that I'm not making some of this up. This is actually from ATI. And ATI has got a great resource. And Amy, if you could put that link in the chat, they have got a very nice next generation NCLEX section that's available to the public. It's not an ATI exclusive web link. So they've got some great links and resources. This was one of them. I'm just going to block myself out for a moment. But what I want you to see with this is that you can see Tanner's framework on the outer ring, starting at the 1 o'clock position of noticing, then the interpreting, responding, reflecting. Look at the inner ring. That's nursing process. You can see noticing and assessment aligned together. That interpreting includes analysis and planning of nursing process, etc. But then look at the inner link, the inner circle. That's the NCSBN model. And that's the 6 steps. But what I want you to see is that the 6 steps of the NCSBN model align with Tanner. And so in essence, noticing is the same as the NCSBN model of recognizing cues. They're saying the same thing in essence. The interpreting of Tanner, NCSBN will say analyzing cues, prioritizing hypotheses, and generating solutions all fall under the interpreting aspect. Responding is taking action of NextGen, and then evaluating outcomes is consistent with evaluation and reflecting. And so what I just want you to see is that if we're teaching Tanner, our students are going to understand and be well prepared for NextGen and all that goes with that. And I think it's really important that we recognize that the NCSBN model is an evaluation model. It is not a practice model, has never been rigorously tested, or research has been done to use it as a practice-based model. It's merely a test model. And so I think it's really important that as educators, when we look at teaching a practice-based profession, we use models that reflect nursing practice, and that's nursing process, and that's Tanner's clinical judgment model. The NCSBN model should not be a curricular model. It's basically, it's kind of like the dog wagging the tail, or wagging the dog. whatever that saying is. It's like, let's not let NextGen and NCLEX drive the curriculum. Practice needs to guide and inform the curriculum. So therefore, let's not use an evaluation model in that complex model and the different layers. Yes, there's some things we can glean from it, but again, let's not teach to the test, and let's not widen the gap between how nursing is taught and practiced, because our practice partners don't use NextGen vernacular of hypotheses and cues and all that goes with it. But they understand the essence of nursing process and Tanner's framework. And so if we use these two frameworks, we can be confident and prepare our students for practice and NextGen, and basically not have to worry about what that looks like in the real world. And so if you have any thoughts or comments, you know what, I'd love to kind of just to basically get your feedback or your thoughts on what that looks like. So don't hesitate to throw your responses out in the chat and what that looks like. And so I just want to encourage you as educators to develop clinical judgment, look at Tanner, look at nursing process. My question would be to you as educators, I know nursing process is embedded in your curriculum. What about Tanner? What about Tanner's clinical judgment model? You know, I want all of you to be agents of change where change is needed to strengthen and innovate your program to better prepare your students for practice. So I want you to go to that link of Tanner, download the article, read it, understand it, digest it, and then get a vision for how you can incorporate this into your practice and into your curriculum, more importantly, so our students can develop the reasoning that's required for practice. And so, you know, Vu says, I'm working with first semester students this summer. I presented the nursing process in Tanner. It's helped students understand what it means to think like a nurse. I've also presented the other clinical groups during lab, and suddenly they're able to have a better understanding of SBAR and SOAP notes. So Vu, well done. And, you know, that's just a testimonial that I want you all to know that, you know what, our students, you know, if we keep it simple and practice-based, our students basically will be able to translate and to really begin that process of thinking like a nurse. Sometimes we hinder it in written care plans that are a little heavy on NANDA and three-part statements. That can be part of the problem. And that's where we need to just be honest and reflect and say, really, what are we doing in our curriculum? Are we helping or hindering the thinking and the reasoning? Are we adapting and using best practices? And, you know, Amy says we use Caputi's Think Like a Nurse from day one. And yes, Linda's book uses the essence of Tanner throughout all of those 4 steps in her different activities. And so, you know, Linda also recognizes the value of Tanner's clinical judgment model. And I just want you to know that this framework really, and ironically in Canada, Tanner's clinical judgment model is mandated to be in the curriculum of every nursing program in Canada. At some level, there is an authority in Canada that says this is the framework in addition to nursing process that we're using. And I think in our country, in the United States, I think that we need to, I just say, look at your curriculum. Is Tanner one of the theoretical frameworks that are informing your curriculum? If it's not, it should be. It should be. And that's part of the problem, because if we're embedding these reasoning steps from day one in fundamentals, all the way through the 4th semester, 5th semester, whatever our type of program is, our students are going to have that repetitive reasoning practice, understanding nursing process, understanding the higher level reasoning of noticing, interpreting, responding, and reflecting, and the importance of those things, those processes. Our students will be well prepared for practice as well as for NCLEX. And so in closing, I just got a little article I just wanted to share with you that I came across by Elizabeth Heron. It was in Sigma's repository. And she did a qualitative study on 18 grads. And she basically had, the article was titled Developing Clinical Reasoning in Undergraduate Students to Promote Success. How can we develop clinical reasoning in undergrad students? Was the essence of her qualitative study. 18 grads that were already in practice. And this is what she identified for themes: that they were better prepared for practice when active learning was used to develop clinical reasoning. Again, we as educators must make learning active. And case studies are one of the foundational strategies that have been successfully used in medical education for decades. And in nursing education, we're not using them quite as much, but we should, because it's one of the best strategies to teach a practice-based profession. They also identified that clinical reasoning should have been started earlier to better prepare students for practice. And so really one of the takeaways from this article that every one of us can grow in as an educator: yes, we teach nursing process in our fundamentals. Do we teach Tanner? Do we kind of introduce our students to Tanner's clinical judgment model and the reasoning of noticing when you're assessing, interpreting the data using pathophys? This is where pathophys is not just a prereq to knock off and say one and done. It's like we got to integrate this, because pathophysiology lays the foundation for interpreting. So again, by making learning active and implementing reasoning from the very beginning, we can strengthen and change our cultures in academia to develop clinical reasoning. And so in closing, I just want you to know that, I've got some resources on Keith RN that I just want to share with you. I've got a free case study, and I've also got a free download that's a portion of the faculty guide on case studies and how to use case studies in your curriculum to teach clinical judgment. So go to my website, keithrn.com. On the very front page, top of the fold, you'll see the ability to sign up for that and to receive that. I also have the educator textbook that is on the website. And this is a resource that, again, takes Tanner's framework, makes it actionable and practical. And I also have a membership for nurse educators. It's called Think Like a Nurse, and thinklikeanurse.co, and Amy will pop that link in. I have over 110 case studies, different levels of complexity, written from my lens of practice, that integrate Tanner's clinical judgment model and those 4 steps of reasoning as open-ended questions. And so educators have been successfully using these cases. I wrote them that way 9 years ago. Before NextGen ever was on the scene, I knew the value of Tanner's framework. And so my cases reflect that. And so I just want you to know that I've got departmental memberships at a discount. You have all the resources you would ever need across the curriculum. It's just my heart to basically be a part and to provide educators with the tools to strengthen and transform how nursing is taught. And so, if you have any specific challenges, I just want you to know that I'm available. And I just want to share my email address. If any of you have a specific question, a challenge about anything that I do, or just really how you're doing, really, I want to know how I can best serve your needs in nursing education. If you have a challenge, a specific issue, be glad to dialogue. And so don't hesitate to reach out by email, and we can kind of take it from there. And so I just want to thank you again for just all that you're doing to be part of that needed change. And I'm just going to see if you have any thoughts or closing thoughts or comments. I'm just kind of looking in the chat here. And I just want to let you know that we'll be back in a couple of weeks, and we're going to be talking about why case studies. I can tell you all, since as I've done my dissertation on the topic of unfolding case studies, I did my lit review on case studies. I'd love to share with you some of the things that I learned in the literature of why case studies are probably one of the best strategies, not the only strategy. I'm not saying that at all, but a foundational go-to strategy that when used across the curriculum, we can bring practice into fundamentals, application of knowledge to everything that we teach using a simple case study and asking the right questions. Open-ended questions, no multiple choice, by the way, because case studies, to be valuable, need to replicate practice. So we'll talk about that in 2 weeks. I hope you'll join me then. If you have any questions, don't hesitate to reach out. And I want to thank you for all that you are doing to be part of the needed change. It's been a pleasure to connect with you tonight, and thank you so much for joining me. Have a good night.